if you come on the stage as well, we're pretty much done. We'll start with discussion. Can we have Dr. Sajjad as well, please? And Dr. Kazim, and Sebastian's already there. Do we have questions?
So my question is regarding the root repairs. So when there is a root avulsion, we see the extrusion of the meniscus. So in order to centralize it, do you put a centralization stitch in the middle with an anchor or maybe anything to stabilize it, or it's you think it's the dynamic extrusion which will go away with the repair? Thank you.
The most common extrusion you see in the medial meniscus. That I think that is the most difficult challenge because it's a chronic injury and all the tissue are and the meniscus are extruded. So I have seen some doctors that even they create the injury peripheral, bring the meniscus anatomically, and then they repair the meniscus. I think it's too much for this condition, no? If you ask me, in this situation, this is the best solution because the idea is to make the root repair is to avoid the osteoarthritis in the future. And if you have the extruded meniscus, you will have osteoarthritis. So I think that you should do something posterior the meniscus and bring the meniscus to the anatomical position. I didn't see in the lateral meniscus, but also there is a technique that you can do that also was shown in the radial injuries, is transtunnel fixation also in the body, in the meniscus. And you avoid the extrusion of the meniscus as well. You do the repair root and the transtunnel in the body.
Thank you. Thank you. Dr. Umar, did you have a question, comment?
So, Sebastian, with regards to the root repair, the question is that if you come across someone at the age of 50, and she's a female, and she has grade 1 or 2 arthritis, physically fit and well, will you do the root repair?
Yes, for sure. The root repair, I don't care the age. I think that you are doing something good for the knee to repair the...
And Conrad, a question for you regarding allograft. Obviously, you know, in Pakistan, we don't have availability of allograft. And I was having a discussion regarding what are the choices we have, because when we see the patients in our clinic and when we take them to theatre or do the MRI scan, there is very huge number of patients who have already meniscus loss because of the chronicity of the disease. They come to us after 4 years, 5 years down the line. You scope them, there is hardly any meniscus. Obviously, we do a very good quality ACL. We do tell our patients that you're not allowed to play professional sports because there is a very high risk of arthritis. But as a knee surgeon, should we not think of developing something new? And I think Ander can also add into this question the use of autograft as a meniscal transplant, which your colleague done in Sweden, and we were interested in considering either hamstring or peroneus to be used as an autograft for meniscal transplant, because it's very easy to get a meniscal transplant and put it in. But if you don't have, then what we'll do?
Absolutely, this is very important question you ask. We also didn't have access to allografts in Poland since, I don't know, last 10, 15 years. Before there was nothing available. Now there are several tissue banks, and I think that this is your responsibility as a surgeon to push, because if you would sit and wait, nobody will do anything. So you have to show the need, and I think if you look at the literature, there is a lot of data that shows there was very nice initiative from ESCA to support the use of allografts in knee surgery. So I think that this is your responsibility as a surgeon to push the authorities and make it possible. But I also I'm aware of this technique of using autograft of SEM-IT. Absolutely, I think it's better than nothing. So there is a lot of data that shows that if you, and I'm going to show later a case presentation of the patient with a meniscectomy and ACL reconstruction, and all the bad things that happened to him just because he lost the medial meniscus. So definitely do something.
Anders, your take regarding your colleague's 6 cases?
We have quite limited experience with this technique. About 15 patients has been done so far, and I think there have been like 3 and 4 revision surgeries with meniscus resection or resection of graft. So it's not perfect. And the MRI after surgery shows that there is something, but it's not normal meniscus tissue. So it's not perfect. I think allograft is probably better.
Okay, so we have with us Professor Shahid Noor, who is obviously president of Pakistan Arthroplasty Society. And Shahid Bhai has done quite a lot of work on tissue banking. Shahid Bhai, we are a nation of 250 population, massive opportunity to develop tissue bank. You've been working quite a lot with regards to that. I heard that you contributed a lot in this field of research and science. Please enlighten us. What do you think? Can we not fight for this and develop our own tissue bank in which we can have meniscal transplants?
Umar, first of all, I would like to congratulate the NEEM meeting. It's a wonderful faculty, international faculty, a lot of discussion, and lots of hands to the entire team that has worked. I totally agree with you that we want the best for the patient, and I think without a tissue bank, it is not possible to conduct revision surgery and complex multi-ligament injury. I, as the past president of Pakistan Arthroplasty Society and president-elect of Asia Pacific Arthroplasty Society, will support 100% that we should have tissue bank in different cities of Pakistan, in Islamabad, in Lahore, in Karachi. At the Liaquat National Hospital, where I am head, I can have a bone bank, but we will be happy to have a soft tissue bank as well.
So, Shahid, please enlighten us. What are the challenges that we cannot have soft tissue bank in Liaquat National?
There are certain legal aspect and there are technical aspect. So one of the organization that you need to get clearance is HOTA. And then the logistic of it, storage and maintenance and the system and the cost. Who is going to procure, who is going to save, who is going to, and then how is it going to be transferred? And would there be a cost, for example, you are doing a revision work and you ask for it, the cost of these. So these are some logistic issues. So there are legal issues, logistic issues and technical issues. But I'm sure where there is a will, we'll be able to resolve all issues.
Thank you. Thank you.
I have a question for Dr. Kasim. Yes. You mentioned that you do the posterolateral approach as well.
Yes.
Okay. So where is exactly the anatomical parameters that you take for this approach, and if there is any risk of, or what risk we should avoid, no, for this because approach?
Thank you very much. It's a very important question. So it's all start with the intercondylar view, where you have to make a posteromedial portal, and then you have to separate the septa between the posteromedial and posterolateral. So this is where there is a blind procedure that you have to do with the help of a trocar. So you have to be very much careful, very much having a protective, very much control. And you can, as you're going to pierce the septa, it will going to be a giveaway. And then you're going to end up with the posterolateral capsule. So here where you're going to feel it, you can give a nick, and then how you're going to make a portal. It's safe until unless you go more posterolateral or more posterior into the vessel, until unless you are aiming toward the posterolateral side, but your hand be more anterior, you will never going to damage the vascularity. So be very careful, very gentle, be controlled, and try to be more posterior anterior rather than posterior to be into the vascular part. So it's very safe, hardly a 2-minute procedure to make it up.
Thank you very much. We'll stop there. We will thank the speakers. They're allowed back. Thank you.